Hi, everyone. It's my great pleasure today to introduce my friend and colleague, Dr. Hamdan. He is a professor of medicine in the Department of Medicine and Division of Hematology and Cellular Therapies here at UC San Diego. He currently serves as the physician in chief for oncology services at Moore's Cancer Center, and he's the interim chief for the Division of Hematology and Cellular Therapies. Clinically, he focuses on the care of patients with lymphoma using CAR T-cell therapy, and he has a research interest in autologous stem cell transplantation. Prior to joining UC San Diego, he was on faculty at Memorial, where he also did his fellowship. And he completed his internal medicine residency training at East Western. I'm really excited to hear his talk today. Reengineering immunity, CAR T-cell therapy, lymphoma, and beyond.
Thank you, Kate, and thanks everyone. Thanks for my team for being here. So today, when I was preparing for today's talk, first, let me say I have nothing to disclose. I don't give any talks, basically. When I was thinking about giving today's talk, the challenge was trying to see how much I can focus it, but also talk about CAR T therapy in a way that it introduces this revolutionary treatment that's been around for a few years right now. So during this talk, I'm just gonna share with you guys how CAR Ts work, why it was a paradigm shift in lymphoma, which is a disease that I'm invested in, and then talk a little bit about the toxicity and why this is a high-risk disease. Share a little bit about here and there about our experience at UCSD, and then talk a little bit beyond lymphomas, and then discuss a little bit why CAR Ts, although they have really revolutionized treatment, why haven't they done that for all diseases? And so feel free to stop me while I'm in the talk, and I'm going to try to monitor the chat as well. So the evolution of cancer treatment has really, I was looking at this, and it's been almost 100 years since we've been trying to treat cancer. And throughout the years, that's really gone from a sledgehammer approach to more of a precision. Audio could be improved. Sounds like our audio is not.
The audio is okay. If you could speak up a little bit,
okay.
I think that'll be good.
Okay. It's there are speakers up there. Yeah. Yeah. Okay. So the treatment went from a very abrupt sledgehammer approach, with using radical mastectomies and nitrogen mustard to treat cancers, and now we're at the level of treating cancers with cellular therapy. And I like to always share this picture because this is the picture of Emily Whitehead, who is the first patient to receive CAR T-cell therapy for a disease that would have, if she did not have that option for ALL, she would have died. And she's been a very strong advocate. She goes around the world explaining to people why research is important. And she just did that not a long time ago. Well, actually, it's almost, a year ago with all the issues that have been going on with abrupting research. And so she's been a great advocate and the poster person for CAR T therapy. A little bit of taxonomy. When we talk about CAR T, and we face that a lot, and when we're talking about cellular therapies, the definition of cellular therapy is really very broad, and it's hard to cover it all, but it does involve adoptive cell therapies, which CAR Ts fall under, stem cell transplant, cell-based vaccines, and this is right now where a lot of the research is being done. And so I've been saying CAR T, but what does CAR T stand for? It stands for chimeric antigen T-cell receptor. And the chimera mythology of a lion's head, goat's body, and serpent tail kind of a little bit applies to the change in receptors of the T-cell to be able to create this living drug that we call CAR T-cell. And so this is a classic figure that explains what is really being done. So basically, the chimeric antigen receptor in the T cell. What's happening is that it's made of three domains. The receptor itself, that's very specific to the cancer cell target. And then there's a transmembrane domain and then a co-stimulatory domain. And this is where a lot of the research is being done in terms of trying to improve the efficacy of CAR T cell therapy. And so as a process, the process starts with, obviously, when there's a decision made for patient to receive the CAR T therapy, there's a leukapheresis, which is a collection of the T cells, followed by the T cell activation and transduction, which happens in a highly monitored, high quality manufacturing facility that's outside of UCSD. First, the process involves T cell activation and basically just making the T cells more active to be able to increase their number. And then there's a gene delivery of the specific receptor that's done through a viral transduction, particularly or most commonly the lentiviral transduction. And I do remember when I first started using CAR T as a treatment that a couple of patients would worry about the virus transduction, asking if they would develop HIV. And the explanation to them has always been that this is only 10% of the HIV virus genome, and it's really it's only a delivery mechanism, very safe, does not involve any replication. After the gene delivery, there's the expansion of the cells, and once the cells are ready, they are returned back to the treatment facility and given to the patient. It is a very lengthy and complex process. It involves, from the time of the initial evaluation and collection of cells, and until the patient receives the treatment, that can take at least 30 days. And this is the reason I bring this up, and I'll come back up later, is because referring patients on time and starting the treatment on time is very critical. And we'll talk a little bit more about that. So why is it important in lymphoma? The treatment for diffuse large B-cell lymphoma, particularly in the relapse setting and the second-line therapy, has always involved salvage chemotherapy and autologous stem cell transplant. And that has been the standard of care since the Parma study in 1995, 30 years ago. And although the autologous stem cell transplant is effective, only 50% of patients who relapse end up being able to go to autologous stem cell transplant. And it only offers 35% of patient remission, 35% of patients after relapse. Relapse after transplant is typically very dismal. And this is a large retrospective trial that involved hundreds of patients that looked at the outcome in patients who relapse after autologous transplant or even who are not candidate and relapse after second-line therapy. And as you can see, the outcome is pretty poor with a median overall survival of 6.3 months. And this study really highlighted the significance of this unmet need in refractory lymphoma and other hematologic malignancies. So then, how is CAR T therapy in second line for large B-cell lymphoma or relapsed B-cell lymphoma? These are the FDA products that have been approved for the treatment, and the structure of the way they differ is with the structure of the CAR construct. All of them are anti-CD19 targets, and the reason CD19 is chosen over CD20 is because we already have a very good treatment with rituximab for CD20, and CD19 is much more ubiquitous on these B-cell malignant B cells. The difference you can tell is in the hinge region or transmembrane region. You can tell there are the first two. They're made by the same company. They have two different names and two different indications. And although it's the same construct, really the difference is by the level of activation that the second product, Brexucab, had. And the reason that is because it's being used to treat conditions like ALL or mantle cell where there's a high level of malignant floating cells. So the activation is really to be able to have more of these T cells to help with disease control. But it's the same product. So before we talk about the use of CAR T in second line, the first trial in lymphoma to look at the use of CAR T is ZUMA-1, where it looked at Axicell. This is the CAR T product that was used. It involved 100 patients who have had at least 2 relapses. And it's important to note that most of these patients have failed after 3 lines of therapy. And 20% of these patients have had already autologous stem cell transplant in the past. It had a significant impact and result in terms of having an objective response of 80% and complete response of 54%, with a 1-year overall survival at 52%. And this has led in 2017 to the approval for CAR T therapy in multiple relapse diffuse large B-cell lymphoma. And so since that was very effective, the major pivotal trials that looked in the lymphoma space as using CAR T in second line treatment. And so these are the major pivotal trials, ZUMA-7, Transform, and Belinda. The reason I'm not going to be talking about all 3, but I want to put them out there because when these trials were happening, we were all wondering which one we're going to be using, which one's going to get FDA approved, which one's going to become the standard of care. And because they all have the same concept, I think the competition has been with which one could be more effective, which one is less toxic. And so if we focus on one of those trials, ZUMA-7, that looked at Axicell versus standard of care as like second-line therapy and relapse refractory high-grade lymphomas. This is a phase 3 trial. It's a 1-to-1 randomization, involved more than 300 patients. And a lot of these patients were refractory to or relapsed in less than a year after first-line therapy. The primary endpoint, which was event-free survival, was met for this trial, and it was at 41% versus 16%, with an impressive complete response rate. Now, when this was ZUMA-7 continued or demonstrated that Axicell has an overall survival benefit, with a primary overall survival at 5 years, with a 5-year follow-up showing median overall survival that has not been reached versus 31 months for standard of care. So the 4-year overall survival was 54% versus 46%. And the progression-free survival was 40% versus 24%. And this was despite the 57% crossover from standard of care. And so the 46% includes those patients that ended up crossing over and going to CAR T. And so with the sensitivity analyses that I'm not going to be able to explain what they are, or be able to tell you what they are, but I trust the statisticians that put this clinical trial together, is that it did show a significant improvement in overall survival or survival benefit. So then when we talk about the different pivotal trials, the question is there one treatment better than the other? And so this is one of the largest meta-analysis or most comprehensive pooled analysis that involved almost 1,200 patients across the 3 randomized trials, ZUMA-7, Transform, and Belinda, and also included retrospective data on real-world data of what we do in the real world. And despite the difference in trial design, the pooled data really tell a consistent story, which is there is benefit in using CAR T over standard of care. And this can be seen across all except for the Belinda trial. And so this was a little bit controversial, and I'll talk about that in a little bit, but the overall survival has been proven to be much higher than standard of care at 53%, the 3-year overall survival when all the pooled data is put together. So then the question is, why do we have a trial that's looking at a similar concept that did not work? And really the consensus is that the trial design was not optimal or was a little bit flawed. But there are other issues that happened in that specific clinical trial. Patients in the Belinda trial have received a lot of bridging therapy before they get to the CAR. And the reason is because of a very long vein-to-vein time. And so when we talk about vein-to-vein, as in from the time the cells were collected to the time the cells have been given, for the Belinda trial has been in the range of 50 days, which is pretty long. And then there's a question about the use of progression-free survival as a data, as an analysis versus event-free survival. But excluding the Belinda trial, there has been consistent proof that this works in second line, and this is why right now the FDA approval for these two products will say that patients who relapse after first line in high-grade lymphoma should get CAR T therapy. The ones who relapse in the early relapse within the first year or after auto transplant as well. And so this is just showing our data that we discuss in our quality meetings that looks at our numbers of transplants and CAR T therapy. And as you can tell, our numbers for CAR T cell therapy has consistently increased over the years, with our autologous stem cell transplant patient numbers decreasing, although a lot of the ones that you see in yellow for autologous transplant account for multiple myeloma. So this is full data for multiple myeloma, ALL, and lymphoma. And also, we've looked at our CAR T experience here at UCSD. And the reason I bring this up is we didn't need to prove that it does work because we know it does. But it was interesting to look at our data because we have really taken patients who are older to CAR T. We always talk about who broke the record, and I think I continue to be the one who took a patient who's 89 years old to CAR T. And so in our data, it did look like patients, we took a good amount of patients who are above 70 years old to CAR T therapy, but also we've had 20% who've had a relatively poor performance status. And so the question, the reason I bring this up is older and frail patients can still tolerate CAR T safely. And this was something that we were able to demonstrate. And also, not surprising that our patients who have relapsed had very poor outcome. And this is looking at the data before we were using bispecific antibodies as therapy. So now we're talking about CAR T and its impact and how important it is. It doesn't come without risks. And so the main risks that are involved related to CAR T cell therapy is when the cell or the CAR connects to the tumor cell and creates the macrophage activation, as well as the systemic inflammation. And this is related to the release of interleukin 6 and interleukin 1 and other inflammatory markers. And so these are the ones that also end up creating the major side effects, which I'll talk about, which is cytokine release syndrome and neurotoxicity. And so there are different ways of managing these toxicities. Some of them include, the early referral. So we used to have a problem with having these patients referred to us in an early time. This has really changed now, fortunately. But early referral is always important because all of these trials have shown that multiple lines of therapy or chemotherapy will lead to T cell exhaustion and probably is a factor in not having CAR Ts work as well as we think we want them to. And then the prevention of severe toxicity, which I'll also talk about in the next slide. We are more comfortable now in instituting measures to treat CAR T therapy in the acute setting without waiting, which was something that we used to do in in terms of avoiding giving steroids for the concern that that might impact those scars. And so the major two toxicities in CAR T in the acute setting that happen within the first 1 to 2 weeks are cytokine release syndrome and neurotoxicity. And cytokine release syndrome is the most common toxicity that can occur in up to 90% of patients. But it's important to note that it's all early or grade 1 or 2 very manageable CRS. And then ICANS is or neurotoxicity that we think is related to IL-6 secretion, is the one that is usually most feared by patients and the one that in elderly patients can linger for a long time. And it can range from confusion and seizures to seizures to even cerebral edema. And so another entity that we're seeing more and more right now with CAR T therapy includes the IEC HS or HLH or macrophage activating syndrome that is related to CAR T therapy. It is not common, but can be serious enough to be fatal. And so some of the treatment strategies include the use of tocilizumab and steroids, as well as an anakinra, which all target the IL-1 and IL-6. And so when we talk about them, about CAR T therapy being having these toxicities in the acute setting, a lot of them are very reversible and tend to resolve with the treatment. And rarely, and it's not common that patients die from CRS or neurotoxicity. But CAR T toxicities can be very prolonged and can take a while to resolve. Not to go through all of this, but this is a very nice, busy graphic that shows the things that patients need to be monitored for after the treatment. It's not really a treatment that you go into the hospital to get and then you're free to go home. And so a very close follow-up is always important for these patients. The most common ones in the long term, as long-term side effects include cytopenias, hypogammaglobulinemia, and infections are always a concern. And the most common, two common reasons for death after CAR T therapy, number one is disease relapse, so patients die from their disease, and the second one is deaths related to infection. And so with this as a procedure being a very complex or complicated procedure, there is a lot that happens behind the scenes that our patients and families don't always see, that our team has to make sure it's happening. It's really a multidisciplinary approach to this, where you need to work with the apheresis team and nephrology, our pharmacists, our ICU team, our neurologists, to be able to make sure that we are providing the safest care for patients. And because it is a cell therapy with high levels of toxicity, it definitely, we're always under the supervision of the accreditation bodies that we have. We are FACT certified, which is the Foundation for Accreditation for Cellular Therapies, and we get audited by that every couple of years, as well as the AABB and FDA, of course. And I'll be coming back to this slide later. I thought it'd be good to just mention that our survival statistics, these are things that we are required by FACT and CIBMTR to present on. They're not looking at things past 1 year or 3 years or 5 years, but our 1 year survival outcomes have been pretty consistent with the literature, and in some cases, I would say even better than what happens in real world data. This is a plug for our quality. And so I talked a lot about lymphomas. The CAR T therapies now are successful or are being attempted in so many other areas or diseases. ALL is the first CAR T success story, as I showed you the picture of Emily Whitehead. ALL has shown, CAR T in ALL has shown that a significant not response rates or complete remission rates of 90% in patients who have really failed everything, including transplant. And those findings were pretty revolutionary at that time and continue to be. The challenge with that is that 50% of these patients tend to relapse, and they often relapse with CD19 negative disease. And so there are other approaches to try to remedy that with dual targeting CD19, CD22. And then CAR-T now is also standard of care in multiple myeloma, and this is where we've been doing this more and more at our center. And before CAR-T, triple class or triple medication refractory patients really had a poor progression-free survival that has significantly improved at threefold with the use of CAR-T cell therapy. And at some point, I believe we started getting more phone calls after the New York Times published, is there finally a curative disease for multiple myeloma, talking about one of the CAR-T products, and we started getting a lot of calls from patients who wanted to come and see our myeloma team, including Dr. Costello, to say, I want a CAR-T. Have that now. And then, venturing in areas that are not my clinical expertise, but very important to talk about, T-cell therapies are also now in the solid oncology world. There are two cell therapies that are approved, lifileucel and afami-cel. I also can't say these and make them very difficult to say on purpose. The lifileucel is a TIL therapy or a tumor infiltrating therapy. It really is involving surgically resecting a tumor, isolating the infiltrating lymphocytes in that tumor that have activity, that are there because they have activity against the tumor, expanding them in the lab so that there's basically a higher number of these expanded anti-tumor T cells, and then infusing those in the patients. And it is the first TIL therapy that has been ever approved. And technically, it's not a CAR-T, but it is considered a cell therapy that is derived from the patient. It has shown very good response in melanoma. And although people think the response is modest, this was in patients who have failed checkpoint inhibitors, so it's considered to be a good treatment. But then the question comes up, why do we not have more CAR-Ts in solid tumors? Why are they not approved yet? I'm not saying they're never going to happen, but why have they not been approved yet? And there's a little bit of, there are reasons behind that, mostly because solid tumors, they have variable antigen expression, unlike CD19 cells. And a lot of time, the immunosuppressive microenvironment of these tumors prohibits T cells from being able to expand. So there's an innate T cell exhaustion going on there. And then there are the physical barriers involving, the tumor microenvironment, which is vasculature, stroma, fibrosis that prevents these T cells from getting to the tumor to be able to do what it used to do. And then there is the on target of tumor toxicity, which is more of a concern in solid tumors because a lot of the solid tumor antigens like HER2 and EGFR are also present on normal tissues and variable organs, so it makes it difficult to target these. And then this is way beyond my clinical knowledge, but I thought it is important to bring this up. CAR-T for autoimmune diseases is basically going to be something that we're looking more into. We already have a lot of clinical trials, or several clinical trials that are open with our rheumatology, lupus, nephrology colleagues that look at the impact of CD19 or other CAR-T in autoimmune diseases. This was a a very exciting trial, the Castle trial, which was a phase 1/2 trial that looked at patients who had refractory SLE, sclerosis, and inflammatory myopathy that received a single infusion of CD19 CARs that ended up showing, as you can see, impressive results based on scores that I don't completely understand, but it looks like these patients were able to be off the immunosuppression. And so the interesting thing about CAR T in autoimmune disease is that it might end, these are patients that require lifelong immunosuppression, and these are now therapies that could potentially take that, be a one and done treatment. I like to show this because these are the therapy pipelines. These are the therapies that are either in that are in clinical trials that are looking at the use of cell therapy in variable conditions. It's not just about oncology anymore. We at UCSD, I believe we have around 60 cell and gene therapy trials that are active across different groups. So then, why do CAR Ts fail? I touched a little bit on this, but most of the relapses we used to think are related to the loss of CD19, but actually this is not the common reason why CAR Ts fail. Really, it has to do mostly with the common reasons have to do with the tumor microenvironment and also that are intrinsic to T cells. So we talk a lot about T cell exhaustion, which is basically patients who have been heavily pre-treated, their T cells might not be healthy enough, even if they got re-engineered to target their tumors, to be able to continue to have the anti-tumor effect. And so a lot of these have to do with either the cancer that gets smarter and evades the CAR, or as I mentioned, there might be some antigen escape, or it is related to the tumor microenvironment. So a lot of research is being looked at in this arena because trying to see what are the mechanisms that cause CAR Ts to fail, to be able to create new CARs or armored CARs that we'll talk about that would be able to evade these issues. I bring this up again to say that although there are intrinsic factors that are related to the tumor and to the CAR T itself, there's a lot outside of that that we can impact. A lot of it has to do with not heavily pre-treating patients, early referrals, being selective about the bridging chemotherapy as to not impact the T cells. And so this might not be directly related to CAR T therapy failure, but I wanted to bring it up because, again, this is a lot of time patients don't end up getting the CAR T, and a good amount of them is because of manufacturing failure. I've had to go through that with a patient of mine recently, where the cells basically were not good enough for us to be able to infuse them, and so that results in delay in treatment. Disease progression is a very common reason to why patients end up not having to receive their CARs, and then these treatments are very expensive. So CAR Ts can cost approximately $500,000 per patient. Okay, so where do we go from here? There's still a lot that we don't know. We still talk clinically among each other about what is the best sequence, what's the optimal sequence, particularly now with the availability of bispecific antibodies that are infusions that can target the CD20 or CD19 and the CD3 on T cells. Do we give CAR Ts first? Do we give bispecifics first? So the sequencing has always been a question, or one of the questions that we look into. Are there certain biomarkers or are there certain metrics on patients that would tell us some patients would probably respond to CAR-Ts better than others. We still struggle with long-term side effects, with late toxicities, with secondary malignancies. This was a huge concern a few months ago or a year ago when the FDA was investigating T-cell malignancies after CAR-T. The question is that related to the CAR-T itself, or did these patients receive already a lot of chemotherapy or prior therapies before that resulted in that? And then there's a question of retreatment strategies. What do we do next? What do we do after patients fail CAR-Ts? We know that giving another CAR will result in less than 20% response, so that's not necessarily something that we want to do again. And then there's a question that I know comes up a lot in ALL. Do we do a transplant or an allogeneic transplant after doing CAR-T? So we still have a lot of questions to answer. But a lot of work is also being done on trying to improve the construct of the CAR-T. Most of the CAR-Ts that we use right now are second generation ones, but there are third, fourth, and fifth generations that are in clinical trial phases. And the names just keep on getting very creative, like trucks, armored, and all of that look at not just the direct effect of CAR-Ts on the cell, but also trying to stimulate IL-18 and others. And so, as I mentioned, there's armored CARs that use IL-18 secretion to boost the anti-tumor activity. This was published in last year that actually looked at patients who have failed CAR-T that received this IL-18 armored CAR with an overall response of 75% and CR rate of 58%, which is very impressive. And so these are in phase 1-2 trials currently. There are the dual targeting CAR-Ts that are being used, that are also in clinical trials, investigating in ALL and myeloma, and as well in lymphoma. There's the allogeneic off-the-shelf CAR-Ts, which I'll talk about in a little bit. And then there are other things that are related to how do we modulate or impact the tumor microenvironment. And so one of the clinical trials that we've been involved with here involves the allogeneic CAR-T, which is basically what we call off-the-shelf. So there's no manufacturing time. These are live drugs that are available at our institution, sitting in the pharmacy or blood bank or wherever they need to be. They are allogeneic because they are donor cells that have anti-CD19 activity. And for this specific one, CD010, the CRISPR technology has been used to be able to eliminate the T-cell receptor on the donor cell to prevent GVHD or reduce the GVHD risk. Insertion of the CD19, and then there's a knockout of PD-1, which prevents T-cell exhaustion. So this is a construct that has 3 different elements to it. And so with this clinical trial, these are patients, again, who have been heavily pretreated. There's a cohort of them that we have enrolled for second line, but not a large number. The CR rate for all of them has been around the 45%. But there has been something that now is being looked at or studied, a question about the improved response depending on HLA matching of these allo cells. So patients who are HLA matched at or more than 4, the current clinical trials that we have is actually looking at patients that have that level of matching to see if the responses would be much improved. This is signaling that this will become a therapy that we will be eventually using. That's something that if the patient has a relapse, you could technically admit them to the hospital in 2 days and give them this therapy. I was very worried that I'm going to be not on time, but I'm very early, but so the summary of this talk, basically, I hope that I was able to convey that CAR T therapy as standard of care. Right now, we have several products that have been approved. It has shown overall survival benefit in lymphoma and other diseases as well. Although it's a high risk, considered a high risk treatment, the toxicities are manageable. And the future is in figuring out whether CAR Ts are going to work in autoimmunity, solid tumors, other conditions, as well as the use of allogeneic CAR Ts. There's still a lot that we don't know. To me, one of the most concerning ones would be, of course, a lot of patients will relapse, but I know that we will have answers to that. But how do we reduce the cost of this very expensive therapy? There's a lot of areas and countries outside of the US that have been able to create CAR Ts at $10,000 or $13,000 within an institution. So we'll see where that goes in the future. With that, I will thank you all for coming and listening to this, and happy to take questions. Yes.
I was just wondering, just after you talked about the like allogeneic products that are in trials, maybe this is a silly question, but just given the concerns about like autologous cells just being exhausted from prior chemotherapy and whatnot. I mean, is there any reason that might be like more applicable in like earlier lines of therapy? Just like allogeneic T cells as opposed to autologous.
You mean trying to do that in earlier lines of therapy? Yeah, I think that will be something that we would look at for sure, right? So, and these trials are trying to look at it right now after first line failure treatment. I think that we do have clinical trials like Zuma, is it 22? 23, that's looking at using CAR T in first line for lymphoma, right? And so this is autologous CAR Ts, and so and we know that that's going to end up being pretty effective. And so there will be a role for the allo CAR Ts to also be used in that first line setting. I don't know if that answers the question. Yeah. And these allo cells are really being selected from healthy donors like we do in allogeneic transplant. So younger patients, male, no other issues going on, right? And I mean, this is kind of how they end up selecting them. Yeah.
Can you talk a little bit about the survival of the CAR T cells? I suppose you can find them in the peripheral blood by PCR or something. How long do they stick around? Is there a relationship between how long they stick around and how effective they are? And why do we get away with using tons of steroids for ICANS and they still work?
I don't know. With the ICANS question. But we do know that actually the blood level in the blood after infusion do drop, right? And it doesn't correlate with response or not. And I have experts with me here, so you guys can also comment on that. They allow Lymphoma and others. But I don't know if there is really a very strong correlation between, like, let's say in 2 years, we checked for CAR T and it's not there. Is that does that mean that there's a risk for a patient to relapse or not? I don't know that there's an answer to that. Yeah.
For Copicel, the ALL product, they're developing a companion drive persistence marker to correlate with MRD. But then the hard thing is I think it relies on a CD19. So if you have a CD19 negative relapse, then that doesn't help you determine.
I think there is some correlation with the steroids, but the steroid has to be like very, very high doses, more than what we would usually get.
Is it also the length of time? I mean, it's amazing to me that there's no work after sometimes several weeks of steroids.
Yeah, I don't think it's a length of time, but the cumulative dose of the steroid. And it's something that's very higher than what we usually do.
And I think that's a good point that you're bringing up, because we used to avoid doing it, and it is effective. It is effective for CRS. It is effective for neurotoxicity. We've been always very scared of pulling the trigger clinically to do it. And then with time, we became more comfortable with it, but we still try to get patients off of it as soon as possible, right? So. Yeah. I can look at. Okay. Yes, I see that here. So there is a comment from Dr. Costello that there's so much excitement for in vivo CAR T that eliminated lymphodepletion and logistics of ex vivo engineering. I agree with that. And then. That was 8.
There is a few questions in the Q&A.
Okay, thank you, Kate.
Yeah.
That's what you think. Yeah. Yeah, somebody.
Oh, okay.
Yeah. So there's a question about if, the role and sequencing of CAR T and CLL and indolent lymphomas. That's a great question, and I do think that for indolent lymphomas, at least, CAR T is effective, like in follicular lymphoma, marginal zone, mantle cell, but we tend to use it more in 3rd, 4th lines. So after people multiply relapse, because the indolent lymphomas also tend to be not responsive to the treatment that we give, and patients can live with it if they're asymptomatic without having to treat them. So it's hard sometimes to go ahead and give a high toxicity, high risk treatment for a disease that is pretty dormant or not causing a lot of side effects.
Is there any data, long-term follow-up that some of the low-grade lymphoma people might be cured?
Actually, it is pretty effective in follicular lymphoma, and the overall responses and CR rates are much higher than that we see with high-grade lymphomas.
And durable, or we don't know?
Durable responses, yes, but I do have to actually, I don't know if we have data that is 5 or beyond, but it is absolutely.
I was actually just looking at a while you're talking,
Yeah.
and I was wondering, but there's the ZUMA-5 trial that looked at follicular lymphoma. I think they're about 30 or 40% more in remission at 6 years, 7 years.
But I find that we do it less and less for our indolent lymphomas just because they do tend to respond to the therapies that we give them and are in remission for a very long time. So that's one aspect of it. The other thing is right now it's going to be interesting is with bispecific antibodies and being able to treat them for a fixed amount of time. Are we still going to need to do CAR Ts or not? It also has to do with the level of comfort of how much you do these CAR Ts. Are toxic, but the procedure itself doesn't necessarily kill patients. I don't know if I'm saying it right. But and so we do in follicular lymphoma, you can argue, or in indolent lymphomas, you can make the argument that it's a one and done treatment, and patients don't need to be on extended time. Yeah.
By meaning longer term.
And then does the use of off-the-shelf CAR T reagents lower the cost sufficiently to consider this a therapy available for all patients? I think that is a great question. And it's also a little bit of a political question because it also depends on where this is being done or what country it's being manufactured in. But I do think that there will be a role to be able to give this at a much cheaper price for sure. I think these were right. Yeah.
I have 2 questions. The first one is, I'm curious about bispecific antibodies after T-cell therapy. So, does using bispecific antibodies in patients who failed for T-cell therapy into issues like T-cell exhaustion and other strategies that can be used to maximize the experiment?
That's a great question, and I think that we don't have the best answers for it yet, right? Because we're just starting to use bispecific antibodies. The thing that I can answer is that it is still an effective therapy after failure of CAR T. So now this would be our next line of therapy after patients fail from CAR T. Bispecifics are also targeting CD20 and CD3, so not always CD19, although an ALL blend is an anti-CD, is a CD19. So that's one thing. And then there's also the question of, I know in multiple myeloma, some of my colleagues will use bispecific antibodies prior to kind of control the disease. And then there's a question, will we go to CAR T after that, right? So these sequence questions, we will have more answers to them. I don't know that we really know right now, but one thing that I would say is that most of our patients that will fail CAR T, we would put them on bispecific antibodies, sometimes with combination with chemo, because there is data that actually they do have a very good response and pretty high, well, relatively speaking. Yeah.
What is the clinical timeline for the development of EMCA in patients? How long can we expect the therapy to maintain efficacy?
So it has to do with, do patients relapse or not? I think this is how I look at it, because we don't measure this on a regular basis. We don't do tests to say, unless it's in clinical trial, we're not measuring to see whether there's continuity of the CD19 CAR or not. So I do think that we look at it based on the disease, the CAR construct, and when do they relapse. And I think that would be a good way of measuring efficacy of those, right? So in lymphoma, we talk about 50% of patients are in complete remission, 50% were relapse. So that's one area that I would say 50%. Okay. Thank you. Thank you, everyone. Appreciate it. Thanks.